Hello, my name is Michael Bartel and I'm an Advanced Endoscopy Fellow at the Mayo Clinic, Florida. Today, I would like to present our study that will be published in the upcoming GIE edition. First of all, I would like to introduce the senior author Dr. Heiko Pohl and the co-author Dr. Douglas Robertson from the Veteran Administration Hospital in White River Junction, Vermont. As part of my medical training, I worked at that VA too. The title of our study is Colonoscopy Practice for Veterans Within and Outside the Veterans Affairs Setting, a matched cohort study. The motivation for this study came from the current practice at VA facilities with outsourcing of routine screening and surveillance colonoscopies to non-VA facilities in order to meet the increased demand for colonoscopy. As of last year, this fee-for-service referral practice made up approximately 1/3 of all colonoscopies being performed by non-VA providers but being paid for by the VA. To minimize wait times, the Congress passed the CHOICE Act in 2014, which allows now veterans the care outside of the VA system when the patients cannot be seen within the wait time goals of the VA or if patients qualify based on their place of residence. We were interested to understand whether colonoscopy care is affected by referring patients to non-VA providers. Therefore, we compared colonoscopy quality measures of screening and surveillance colonoscopies performed within one VA facility with colonoscopies referred to regional endoscopy units outside of the VA system. We included all patients between the age of 50 and 85 years who were referred for screening or surveillance colonoscopy from the White River Junction VA to non-VA facilities between the years 2007 and 2010. The referral practice included academic and non-academic facilities, and the colonoscopies were performed by gastroenterologists or surgeons. The decision where to perform the colonoscopy was based on personal preferences. These non-VA care patients were then matched to a control group of patients who received a screening or surveillance colonoscopy within the VA. These control patients were matched one-to-one by gender, age, and year of procedure. The main outcomes of the study were the adenoma detection rate and adherence to multi-society surveillance guidelines. Patients with concomitant lower GI symptoms, a positive fecal-occult blood test, or a history of IBD were excluded. We included all patients between the age of 50 and 85 years who were referred for screening or surveillance colonoscopy from the White River Junction VA to non-VA facilities between the years 2007 and 2010. The referral practice included academic and non-academic facilities, and the colonoscopies were performed by gastroenterologists or surgeons. The decision where to perform the colonoscopy was based on personal preferences. These non-VA care patients were then matched to a control group of patients who received a screening or surveillance colonoscopy within the VA. These control patients were matched one-to-one by gender, age, and the year of procedure. The main outcomes of the study were the adenoma detection rate and adherence to the multi-society surveillance guidelines. Patients with concomitant lower GI symptoms, a positive fecal-occult blood test, or a history of IBD were excluded. A total of 409 mostly male patients with a mean age of 64 years were referred for a non-VA colonoscopy, were matched to 409 patients in the control group. The majority of colonoscopies in non-VA facilities were performed by gastroenterologists in 30 non-academic and 2 academic facilities. The colonoscopies at the VA Medical Center were performed by 11 gastroenterologists, all with an academic affiliation. In terms of the adenoma detection rate, we found a significantly higher adenoma detection rate, more adenomas detected per procedure, and also more advanced adenomas in colonoscopies performed at the VA Medical Center compared with colonoscopies from non-VA facilities. For instance, veterans who received their colonoscopy outside the VA had an adenoma detection rate of 38% compared to 52% who had their colonoscopy within the VA. These differences persisted when only colonoscopies performed by gastroenterologists within and outside the VA healthcare system were compared. However, no differences were found between gastroenterologists and surgeons, as well as between academic and non-academic facilities in patients who were referred out of VA healthcare system. In terms of the adherence to surveillance guidelines, recommendations were significantly less frequently documented and also less adherent to guidelines in non-VA colonoscopies, particularly if the procedure was performed in a non-academic setting or by a surgeon. Most importantly, on multivariate analysis, colonoscopies performed at non-VA facilities were independently associated with a 36% lower chance of being diagnosed with an adenoma, although the endoscopist specialty and the academic affiliation were not independently associated, with differences in adenoma detection rate. In summary, in the same patient population, colonoscopies performed at the VA had a significantly higher adenoma detection rate and adherence rate to surveillance guidelines than colonoscopies in non-VA facilities. Our study has several limitations which need to be pointed out. First, we cannot exclude possible non-measured confounders like, for example, history of smoking, quality of bowel prep, differences in waiting times for referred patients, participation in quality improvement projects, differences in withdrawal times, or the individual endoscopist adenoma detection rate, although both cohorts were well matched. However, we suspect other than patient factors to be responsible for the differences in adenoma detection, particularly factors related to system or facility. For instance, the daily volume at non-VA facilities may be higher, which may have an effect on performance. Further, a possible detection bias needs to be considered in the VA medical center, as veterans have a higher adenoma risk than general population. And also financial incentives may play a greater role for endoscopists in the private practice setting than within the VA healthcare system. Moreover, the retrospective character, and especially the narrow regional restriction to northern New England, limits the generalizability of the findings. A recent study by Johnson and colleagues published in Gastroenterology last year showed a very broad variation to adherence guidelines across VA medical centers. In other words, what we found in our study may not be representative for other regions. On a positive note, the adenoma detection rate met benchmark criteria for adenoma detection in both VA and non-VA cohort. This raises the question if the measured differences would have any impact on outcomes like mortality or interval colon cancer rate. In conclusion, this regional study shows that colonoscopy quality may differ when performed in non-VA practice settings. Referring veterans outside of VA medical centers may not always affect care for the better, and further investigation at the national level may be warranted. Thank you.